Good morning, everybody. Nice to be here among people I've known for a really long time, and some people I've known for a short while. And I want to thank the governor for appointing me to the Medicaid task force. It has been a wild ride. Really, a lot of people working very hard, and we've had some very good discussions. I'm really looking forward to part 2, where I think we get to step back a bit and really do a deeper dive in terms of what we've been doing already, what's worked well, what do we need to change, what lessons have we learned, and how do we all move together to create a strong, keep our Medicaid program strong, and so that it can serve the more than 1 in 4 Rhode Islanders who are enrolled in its high-quality health insurance program, and also the Medicaid program, as people here know, is the payer of long-term care services for seniors and people with disabilities. So we thought it was just really important to start our conversation today with just looking a little bit about who is enrolled in the Medicaid program. And I wish we had sort of Rhode Islanders, pictures of Rhode Islanders or stories of Rhode Islanders, but we have our stock photos. If you go to the next slide, as children and families in our RIT care program, and the numbers, you can find numbers. Today the number will be different than tomorrow, and you can look at different sources, but generally 147,000 children and parents are enrolled in our RIT care program, which really was the managed care program that started in 1997, converting enrollment of people who are on the AFDC program. And we're all very nervous about the managed care program when it first came into play, but it has grown to be a fantastic program. The 2 managed care entities that provide services to their members. So 92% of the children and parents are enrolled in the RIT care, one of the 2 managed care plans, Neighborhood Health Plan of Rhode Island and United. 6% are in our RIT share program, and that was another innovation in Rhode Island back in 2000, is in part driven by budget changes to say, let's look at how we can bring employer dollars to the table. And that was set up with Patricia Letty, who was one of the architects of that program, to make sure, so in that program we've got people who are working and they pay their health insurance to their employer contributes, and then the state reimburses the individual less a premium amount that they pay to have employer-sponsored coverage. And if you're wondering where the other 2% went, there's still 2% of children and families who are really in fee-for-service, where there's just direct payment providers. They're not enrolled in managed care, they're not enrolled in employer coverage. 9 out of 10 of the children, the families enrolled in RIT care are working or unemployed. And I point that out, there's about 13,000 Rhode Islanders who get cash assistance, who also get RIT care coverage, but everybody else, out of that 147,000, are not receiving cash assistance. They're either in the workforce, they're working at jobs part-time where they're not eligible for health insurance coverage, or they're at a job that just doesn't offer health insurance coverage. So our RIT care program is really going to dig into businesses and to our economy by making sure that we have a healthy workforce. And most of them are very low income. While our children eligibility goes up to about 2.5 times the poverty level, all of the parents on RIT care have income less than 138% of poverty, and most of the kids are below 138 as well. Go to the next slide. Continuing with children and families, there are 9,000 children with special health care needs who benefit from the Medicaid program, and about 2,200 children in foster care or who receive health insurance coverage. They've been adopted and they have special health care needs, and they're eligible to continue to get health insurance coverage through the RIT care program. And I should mention here, it's not on the slide, but one of the wonderful expansions in the Affordable Care Act was to say that children who grow up in the foster care system, when they turn 18, they're eligible to continue to get RIT care coverage until they turn 26. And that's to provide parity with the ACA rule that says that all of us who have commercial insurance can keep our kids enrolled on our coverage until they turn 26. And I benefit from that because my daughter would not otherwise be insured, I think, or must be much more costly. So where the state has stepped in as the parent, we keep those kids on foster care, in foster care as well. I'm sorry, when they're in post-foster care, they continue to get health insurance coverage. Moving on to seniors, there are about 22,000 seniors, people age 65 and older, who are enrolled in our Medicaid program. The majority of them also have Medicare, and I think we'll hear some discussion about the integrated care initiative that Rhode Island is going to embark on a phase 2 to make sure that we're providing integrated care for those individuals across primary acute care and long-term services and supports. And for adults with disabilities, there are about 31,000 people with disabilities enrolled. That includes people with intellectual and developmental disabilities, adults with severe or persistent mental illness, as well as individuals with physical and other disabilities. So for those folks in particular, the Medicaid program not only provides access to critical acute and primary care services, but often the home and community-based services that people need to live safely in their communities. And finally, the last and latest population, and thanks to Steve and Ann for helping to make this happen, as a country, we will provide high-quality health insurance to all of our residents. Unfortunately, not all states agree with that. But in Rhode Island, we took up that option very quickly, and currently there are about 57,000 low-income adults without children who are enrolled in health insurance coverage. And again, many low-wage workers, people who are working at part-time jobs like this, or working as waiters, as this guy in the picture. Also, older people who may be, can't call them older anymore because it's now me. No longer have health insurance at their job and are not yet eligible for Medicare coverage, and are now eligible to get Medicaid coverage in the interim. I just want to point out here, we're just going to talk a little bit after sort of who is benefiting from the Medicaid program, a little bit about some of the financial dynamics. But I just want to say here that in 2014, when we started to cover the single adults, as most people know, that was with 100% federal funding, and that brought $500 million into Rhode Island's economy in 2014, which was a tremendous boost for our state. So not only did we start to be able to provide comprehensive health insurance to folks, but it was really an economic driver for Rhode Island. Which is a good segue into the next slide. Again, just some high-level basics about how Medicaid is a funding partnership between the federal government and the state. And obviously, as the federal matching rate changes, the state's share of costs changes as well. So the reason I'm showing this slide is that in 2010, the state share of Medicaid costs was about 36%, and in 2012, the state share was 48%. Anybody know why that dramatic difference in what the state share was for those 2 years? Right. So during the recession, the federal government stepped up to the plate and said, states are hurting, we want to make sure they don't cut coverage for people. So the federal government increased the matching, the percent of the matching rate that it gave to states. So the reason I also point this out is not just to show how the federal government is a good partner, but also to show that if you hear numbers about what the state share of costs is for Medicaid, and how that may have grown over time, it matters, the starting point matters. So if you look at 2010 and you say, oh, the state costs in 2010 were $716 million, and you compare that to what we're spending now, you're going to have a much larger increase in the state share, or the state costs, than if you use the base from 2012. So just beware as you're reading articles or hearing information about the state cost. You have to know where we're starting from. And then just a little bit again about the funding partnership. So our regular matching rate now is about 50%. So for every dollar we spend, 50 cents from the feds, 50 cents from the state. The expansion population, as I mentioned, is 100%. federally funded, and that will gradually decrease until it reaches a 90% match rate, and it never goes lower than that. So we have ongoing 90% federal match rate from the federal government. We'll have to pay 10%, and that would be $50 million when we get to 2020. But hopefully we have the commitment, and I was really glad to hear the governor talk about we're not changing the Medicaid program this year by reducing eligibility, and hopefully we're going to stick to that we're going to make sure that we take advantage of everything we can to keep people insured. And lastly, or almost lastly, when we're thinking about Medicaid expenditures, that's obviously a combination of both enrollment and how much we spend in terms of providing care, right? So you could say Medicaid expenditures is enrollment times per member per month. So here you can see, and this is the latest information that I could find just from the state Medicaid report, and hopefully the new annual one is coming out. But this just shows the over the period of 2009 to 2013, our enrollment was growing and our per member per month costs were really declining. Okay? I should say over this time too that in 2014 we did actually save money in the Medicaid program by cutting eligibility, and we reduced eligibility for parents from 175% of poverty to 138% of poverty, and we saw about 4,000 parents lose their right care coverage. The plan was that they would buy in through the exchange, and the state provided some state assistance to help them do that in addition to the federal assistance. But I think we lost about 1,000 people, and we don't know whether they're reported or not at this moment. So those rollbacks really impact particularly low-income families, so hopefully we'll never see that again. And last, before we get into the good part of the program, is just, again, to think about Medicaid, and again, this is from the annual report, that Medicaid trends have compared favorably to national Medicaid trends. So you can see here that over the period of time that we saw in the prior slide, 2009 to 2013, our Medicaid average annual expenditure increased by 1.3%, while nationally it was projected that the increase would be 3.8%. And then if you look at what's happening on the commercial side compared to Medicaid, and you look at our per member per month spend, we actually had an average annual reduction of 1.5%, while on the commercial level, just looking at what it costs to insure individuals, that was going up by 2.8%. Okay, so our Medicaid program is good. Do we need to make some changes to make it better? Absolutely. Have many people in this room been working really hard to improve access to long-term care services for folks, to better integrate behavioral health and physical health services? Absolutely. Have we worked really hard to raise up the issue of what happens to children as they age out of our kids system into our adult system? Absolutely. So it's very exciting to me that we now have the opportunity with the leadership of the governor and the leadership of Secretary Roberts and Deputy Secretary Wood to really make those changes. Working with all of the staff who have been at this for a long time, and working particularly with community providers and advocates who I think we're all very excited about moving forward. So, thank you.